Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
James, we should continue a conversation about intratumorals. We were talking, what did we talk last week or last time, I should say? We were talking about TVEC and the Optum study. And now I think the obvious question became, can you start combining these with checkpoint inhibitor? So now not just intralesional, but address more systemic disease. So there's a study we wanted to talk about, the MASTERKEY 265. I think you know it intimately well. You were the discussant at ESMO in 2021, if I'm not mistaken. Before we get into that, maybe we'll just do a quick fire question or two. Selfishly, I have a question. What's the difference between MI5 and MI6?
So one's internal and one's external, I think is the really quick answer. Oh. So I think that's maybe analogous to the CIA and the FBI, roughly speaking at least. CIA external, from what I understand, not allowed to operate on American soil. And then FBI internal, although they have different roles. Whereas, yeah, it's the same distinction for MI6 and MI5. So we're told.
Yeah.
MI6 is external, a bit more like the CIA, I suppose. MI5's internal. Okay. I think. I'm not an expert.
Well, good. That means you're probably not an MI6 agent. Although, isn't that exactly what an MI6 agent would say?
Yeah, I could tell you a few stories about that as well, but they're probably sort of not right to do now. But I've certainly got some friends from college, having been to Oxbridge. Who I quite often. I mean, I had this friend. I can't tell you his name, obviously, but he was doing stuff like trekking to the North Pole and going on holiday in Pakistan and Afghanistan 20 years ago. And I did seriously think, yeah, that's not the kind of thing most people do, but, whatever.
Yeah, especially if he's a single guy without a family. That's who they target, right? Like, I'm the perfect recruit for the CIA, if anybody's listening. A single woman who's not attached to, you can't hold my family hostage. Yeah. And you can't use leverage. Family is leverage.
Yeah, you've got a good story.
What's the last book that you read, or do you read books?
No, I don't. I don't unfortunately often get much time, but I've been reading. I think I might have told you this. These Slough House books, SLOUGH, by a British bloke called Nick Heron. So there's a link, isn't there? So they're about a sort of a failed branch of the security services, basically, where people get sent to sort of in the hope that they'll resign because they've kind of messed something up anyway. But the reason I got into it was because of the adaptation, which is on Apple TV, I think, with Gary Oldman, who plays the main character, which is just amazing. I don't think you've watched it, but it's just, I think you'd like it as well. So then we started reading the books, and the books are good too. So there's the answer.
We know Slough from the British Office. It was, they were like a company out in Slough. So that's how we all learned that city or whatever.
Yeah, Slough's quite sort of famous for various reasons, most of which have negative connotations.
Right.
But probably shouldn't say any more now.
All right. Well, let's talk MASTERKEY 265 TVEC, telimagene laherparepvec, that we're familiar with in combination with Pembrolizumab. This was an interesting study because it was a phase 1B that turned into a phase 3, all under that heading. MASTERKEY 265 is my understanding. Maybe you can just inform us, if you're aware, James, the background on this or how it really evolved and what the study.
I think that's right. And so, I mean, important study, interesting study, and it sort of maybe comes under the heading of important negatives in some ways that we've talked about before, I think. So I think from a scientific perspective, it made a lot of sense to combine TVEC with anti-PD-1, so we can be clear about that. And then I think the phase 1b had maybe 19, 20 patients or something like that in it. Actually pretty, I can't remember off the top of my head, but pretty significant efficacy was shown in the phase 1b, and the tolerability actually looked, I mean, maybe apart from a few injection site reactions, looked like not far from anti-PD-1 alone. So as ever, I think that provided the basis for then jumping into a randomized trial. And then we now know, and we'll talk about the fact the randomized trial was negative. So I think that's the cautionary note. And that, you know, this wasn't the first time something like this had happened, and I'm sure it won't be the last time, because there's a lot of different competing pressures to try and jump from an early trial to a late one. And so in a way, I wouldn't be too, I was going to say I wouldn't be too critical of that, but carry on.
Yeah, I mean, I think the only thing I was going to make is that that's the lesson for industry, right? For designing these trials that go from phase 1 with a handful of patients to phase 3, where we've seen this happen. The patient populations either don't overlap, the demographics aren't identical. What's happening when I worry a little bit about this with our mRNA vaccine that came out, and you just have to be careful. The mRNA vaccine study in particular has a different eligibility criteria from the randomized phase 2 as it's going to have in the phase 3, or has now that it's enrolling. That's where things can really give you an entirely different signal. And that's what's at play here, but why don't you carry on and tell us about the study?
No, but yeah, I mean, just to comment on that though, before we get into the study, I mean, I think a lot of this comes back to, maybe even thinking about a randomized phase 2 to benchmark a bit earlier on. Because this is one of the oldest rules of oncology. Martin Gall, my friend and mentor, used to teach me this, when I was, still in short trousers, as they say, that, a lot of the time you can halve the response rate from a phase 2 when you look at phase 3. So that's quite a kind of old school type of message, but I think it speaks to patient selection in particular. I think the other thing that, when one goes to advisory boards, especially with small biotechs actually, but I think all of industry, is that sometimes you see the data, it looks great, but there's never enough, never enough focus, in my opinion, at least, on the baseline characteristics of the patients. Yeah. What would you really expect? And they're almost always highly selected. They're at specialist centres, and almost always you get a kind of rarefied selection of patients with better disease biology who are going to do better. So I think that's one of the catches here. Anyway, if we just sort of put all that to one side, going on to phase 3, yeah.
It's hard to go past the short trousers comment without just a visual of you seeing patients in short trousers. Did you mean short coat or short trousers, truly?
No. It was metaphorical rather than being literal, at least I think so. Yeah, well, that whole expression, in short trousers.
Literally,
just means,
here in the US, there's some medical places where when you're a medical student, you're in a short white coat. Actually, that's most places. And then an intern is slightly different, and then a resident attending differently. So, the short coat, long coat means something, but short trousers, long trousers, it's an image.
It's probably subject of the whole podcast. But yeah. Anyway, so so let's maybe talk a little bit about the phase 3. So I think it was presented at ESMO, sort of somewhere in the middle of COVID. My memory's still somewhat hazy about that time. But I think I may have done the discussion kind of online rather than in person. So this is a decent sized, and now I'm looking at the publication JCA beginning of last year. Jason Chesney is the lead author. Decent sized phase 3 trial, 1-to-1 randomization. So Pembro placebo or Pembro TVEC. I think both administered pretty much according to the sort of single agent schedule, shall we say. 700 patients altogether. And the headline is about the primary endpoint, which was progression-free survival. And so basically it's 0.86 with confidence intervals from 0.7 to 1.04, so not statistically significant. And then the OS, just for the record, the hazard ratio there was 0.96. So, I mean, I suppose what you could say about this, at least in terms of PFS, there was a little bit of a signal there, but that hazard ratio obviously didn't meet statistical significance. I
Right.
think just another thing maybe to say in passing is there was a little bit of difference in response rate. 49% for the combo arm, 41% for the placebo arm. Durable response rate was a bit different as well. Actually, maybe just two more quick things on efficacy before we perhaps talk about reasons why the trial was negative. One thing I think to say is that actually the toxicity between the two arms was really exceptionally similar. There really wasn't much at all in the way of difference between the two arms in terms of toxicity. So basically both pretty well tolerated, and I think about 20% grade 3 or worse treatment-related AEs. So yeah, that's kind of the top line data, I guess.
I have a couple of thoughts. I mean, one is this is the first time when you look at the forest plot by region, you see the US actually having a favorable signal. I mean, sometimes what you hear our colleagues say is just by being Australian or just by getting treatment in Australia, you end up with a better outcome. Here, for some reason, the US cohort was favoring the TVEC over placebo. It means nothing to me, really. The second thing is that the TVEC approval in that Optum study, as we reviewed it, the primary response or primary endpoint there was durable response rate. I believe that's what got it approved. And here it was PFS with OS co-primary or however they described it, not looking at durable response rate. Do you think that's a design issue? That was an opportunity lost? What do you think?
I mean, as ever, the benefit of hindsight's a wonderful thing. I mean, it could have been done with durable response rate. Would it have made a difference? I'm not sure, actually.
Yeah.
I'm not sure there's a strong enough signal here to differentiate it on either PFS or any metric related to response rate, both as surrogates, obviously, of OS. So, I mean, I think for me, and what I would really say, one of the take homes for the study is not maybe just get into the patient characteristics, but we talked before about Optim and how heavily selected the patients were to go into that trial, which demonstrated an advantage over GM-CSF. And I'm just looking at table 1 now in the JCO publication for patient characteristics. And what you can see there, if you just pick out one or two things maybe, is that now you've got a situation where pretty much a third of patients had an LDH which is greater than the upper limit of normal. 20% M1A, stage 4 M1A, 15% M1B, 42% M1C. So really, it's quite a different patient population from the Optim study. So I don't think any of this is to say that TVEC doesn't have activity. We know it already does in appropriately selected patients, but actually when you're putting it together with anti-PD-1 monotherapy in this broader group of patients, there doesn't seem to be too much activity. And I suspect, if you like, that most of the work's being done by the anti-PD-1 here, and some of the efficacy of the TVEC is probably being subsumed. That's, and again, the toxicity was very, very similar. But the geographical variation in studies is almost the subject of a podcast in its own right, because once you start going and looking at those subgroups, the ones I know best are in renal and melanoma. There's several kidney cancer studies where different geographies, if you look at those plots, and it was something that biologically we were interested in trying to interpret right, we'd all be doing it. But typically we will shrug our shoulders about it and say, so what? And actually in Checkmate 67, if you look at US versus Europe, Ipi/Nivo, this is all out there, Ipi/Nivo did a load better in the US than it did in Europe. So, you can try to control your baseline characteristics, obviously, to make these retrospective subgroup comparisons, right? But then the other thing, I think, is the issue of bias and factors that we don't understand that might vary from place to place, which I think, and this, of course, assumes the biology is the same. I mean, your Australian example, if we're talking about BRAF mutations, there probably are actually differences in biology there. So there might be differences in biology, but I think a lot of it is various types of bias. Plus, if you're looking at all these subgroups, you're going to pull out some things from time to time, which might just be chance, obviously. Anyway, back to you.
Yeah. Well, I think there's maybe not a whole lot more to say. You talked about efficacy, you talked about toxicity, and really the key that the baseline characteristics may be quite different than the Optum study, may be leading to this different outcome here from their phase 1, even that they ran, that was just probably too small to really recognize. The Optum study also had that funny cutoff of 1.5 times upper limit LDH. Here it's upper limit or 2x upper limit. So also it's really hard to tease out which of this population would have been in that Optum study. Ultimately, though, we'll talk in another podcast about combining TVEC with IPI, and then interestingly, what that shows and whether that's biology or just it comes down once again to patient demographics. So what else? Anything else you think for MASTERKEY 265?
No, but I'll stand by saying I think it was an important study, but an overall negative, but I think quite a lot of useful points to take away from it in terms of trial design for the future.
Agreed. All righty. Well, that's a wrap. Thanks, James.
Thank you.
Fact check, take 1.
So in terms of route of administration and frequency of administration of TVEC, just to say that the initial injection was followed by another injection 3 weeks later, and then once every 2 weeks until dose 5, and then every 3 weeks thereafter. I would still take a view that although that wasn't exactly the way that TVEC had been administered prior to that, and in general clinical practice, I'd be surprised if that made much of a difference to efficacy.
Yeah, I think you're right there. I was hesitating on the primary endpoint, if it was a co-primary endpoint. So the MASTERKEY 265 had dual primary endpoints of PFS per modified RECIST 1.1 by blinded independent central review BICR, along with OS, overall survival. And just for anybody who's interested in statistics, the alpha was 0.05, two-sided alpha, so it could go either way, but it was two-sided for PFS at a 0.005, and then the remainder of that alpha was weighted for OS, so two-sided 0.045 for overall survival. So it's a co-primary endpoint, but it was weighted more towards the overall survival. Great. Thanks very much.
Thank you.